As the leading professional association dedicated to infection preventionists, APIC provides the resources, thought leadership, education, and comprehensive training to help you protect those in your care. More than 15,000 IPs globally depend on APIC to help them develop and manage top-tier infection prevention and control programs. Join APIC today and unlock exclusive benefits such as educational content, access to cutting-edge research via our journal, and networking with peers to propel your career to new heights.
You are listening to the 5-Second Rule podcast presented by APIC, the Association for Professionals in Infection Control and Epidemiology. This podcast is produced by the APIC Communications Committee and is intended to be a conversation between our hosts and professionals practicing in the infection prevention and control industry. You will learn and be entertained, but most of all, we hope you will be inspired by our community and the work of our peers. And now, on to the show.
Welcome to the 5-Second Rule podcast. We are your hosts. I am Kelly Holmes, and my preferred pronouns are she, her.
And I'm Lerenza Howard, and my preferred pronouns are also she, her.
Hi, Lerenza. How are you?
I'm doing great. How are you, Kelly?
I'm good. Before we get started with the show, I just wanted to talk a little bit about International Infection Prevention Week, or IIPW. It was actually established in 1986 to highlight the significance of IPC in healthcare, communities, and across the globe. It also celebrates the role of the IP in reducing the threat of HAIs and helping everyone to benefit from safer healthcare practices. So you can go to infectionpreventionandyou.org for more resources and information, because we know that IIPW Week is coming up, and these resources are actually available all the time. So definitely check out that website.
Thank you for that information, Kelly. IIPW is always an exciting and amazing time of year for us IPs. That recognition is absolutely well received, at least from my end, and I look forward to moving the needle forward. In this episode, we are joined by two of the APIC Health Equity Committee members, Caldwell Lewin and Jessica Tarabay. Caldwell is a dedicated healthcare professional with extensive experience in nursing and infection prevention and control, and currently works as an operating room registered nurse. Jessica is an infection prevention leader with 12 years of healthcare experience, identifying areas of improvement through interdisciplinary collaboration, data analysis, and implementing strategies critical for successful outcomes. Welcome to the show, Jessica and Caldwell.
Thanks so much for having us.
We are so happy to be here.
So I am very, very interested in hearing more about the Health Equity Committee. And I know we've discussed before this show my excitement to attend the presentation at the APIC conference this year from the committee. So share with us, Jessica, provide us with more information and tell us about the Health Equity Committee.
Yeah, the Health Equity Committee is a committee of APIC, and it started from a health disparities and health inequities task force. And really, the committee is charged with advancing health equity and reducing disparities through the lens of infection prevention and control. And so the particular focus is really addressing regulation, systems, policies, and institutions for which inequities result in adverse health conditions and outcomes of disadvantaged population. So that's including really those racial and ethnic minority groups, populations of lower socioeconomic status. And really our initial goal is to best understand and develop strategies to engage stakeholders for policy change, collaboration, health literacy, cultural competence, and training of a diverse group of infection preventionists. We really want to meet infection preventionists where they are in their particular practice setting, and that doesn't look the same in each of those domains. And so that's a little bit about the Health Equity Committee. We've done a lot of work this last year and just really excited to see where we're going.
Absolutely. And I'm very excited to hear more about the committee, as of course we know a plethora of health disparities that exist. And it will be great for us as a community and as a profession to come together to mitigate that.
Yes, I agree. You all have a big task that you are tackling with health equity. It's a lot to look at and to put parameters around. So, can you tell us, I guess, in general terms, like defining health equity for the listeners, why we feel like it's important in our healthcare landscape and kind of what the IP role is within this health equity domain?
So I think where we have to start is CMS. So we do follow CMS definition of health equity, which is very long and specific, but to like really narrow it down, it's the fair and just opportunities that are obtained to achieve optimal health. And this is despite all the things that can get in the way of that or interfere with that. And those include access to healthcare, various communication barriers, psychosocial barriers, and even our own implicit bias. And so our committee got together and we kind of really narrowed down what is that definition for our committee focus. And the definition that we landed on is the consistent and fair treatment within the realm of infection prevention to identify and address the underlying social and structural constraints of health in our healthcare delivery as it pertains to healthcare-associated infections.
Oh, I love that, Caldwell. That is a very specific definition that clearly states the purpose of the committee. And I think that it's nice how it frames it in terms of really population health. You know, we get bogged down in looking at each case by case, and certain risk factors, but really kind of pulling back and seeing what other social economic statuses could be right in front of us in the data, and we just haven't used it yet to unlock some new hypotheses, really. So yeah, that's really helpful. Thank you.
Absolutely. And on to, discussing socioeconomic status. Jessica, I would like to hear from you as far as it relates to what role does social determinants of health, what role does it play in creating and mitigating health disparities? So I know from, where I reside in Chicago, there are a multitude of health disparities that exist. And us as healthcare professionals, we have to be, knowledgeable of the populations in which we serve to provide them with adequate resources to ensure that there's continuity of care once they're discharged. So share with us, Jessica, about that.
Yeah, so the social determinants of health are huge factors. And that really is, when we're talking about social determinants of health, we're talking about a patient's income status, their education, food security, job security, housing, and really their built environment. And I think it's really important as we really look to this. If you don't remember anything that comes from this podcast today, just really remember this is that research does show that the social determinants of health can be more important than healthcare or lifestyle choices. And so sure, we can do what we can in the hospital, but how are our patients educated? Do they have the resources needed to care for their conditions when they get home? Do they have nutritious food? Are they in close range to pick up their medications or manage their IV antibiotics? Do they actually know how to care for their surgical site or dressings once they leave the hospital? Do they have clean drinking water? So the care continuum is so important as we really start to think about where our work falls into place within improving infections. And I think as infection preventionists, IPs really can advance social determinants of health and really influence policies, especially in underfunded health facilities, critical access hospitals, and just also knowing what actual patient populations that their facility is actually serving, because that's where we can help guide and really kind of help streamline some prevention efforts that goes across the care continuum.
Absolutely. And there's the necessity for additional research to really drive home the need and empower IPs related to the need for those policies as well.
So Caldwell and Jessica, can you give us an example of, this might be an overwhelming thing for an IP to hear, right? Oh my gosh, what we have to collect, what are we collecting now and what do we do with it? But just to like operationalize it for us, can you give us an example that the listeners could relate to?
I think there's a couple, and I think the first start is it is hard not to feel overwhelmed and feel like this is a huge burden and how do I make an impact? And I think it really is, looking at, like Jessica said, your population that your hospital serves, and then what questions can I ask? Like how do we dig into this so that we're possibly taking the first step to including some of the additional data and factors. And one of the things that our hospitals ended up doing is implementing in our HEI, I guess, investigations or deep dives, whatever terminology you want to use, is really adding those social drivers into the discussion when you got into the debriefing. And so really just putting forward those items that we're not always used to talking about or comfortable discussing so that we could really consider other factors that are at play. And I think, like Jessica said, if you have a patient with a surgical wound that's going home, we may not be thinking that, to ask the question, do you have running water? Do you have, access to change and put a clean dressing on the room? So I think really thinking through that. And I would say, one of the big wins that our committee and APIC has had is with NHSN, we'll be collecting the real data, which is that race, ethnicity, and language. And that is going to really help us start to capture some of that data that, we so desperately want to help, look at what are some of the factors that are contributing to these HAIs.
Oh, for sure. I think that by collecting that real data, we'll be able to look at the information through a different lens and perhaps pick out some more patterns that will be helpful to drive our improvement programs. But, one of the examples we were talking about before the show was, perhaps that college student who is discharged home on antibiotics that need to be refrigerated. And maybe they don't have a refrigerator in their dorm, or they, have one that won't keep the temperature. And, where does the discussion go from there? Do you feel like that's a good example of, what we might experience?
I
think it's,
yeah, go ahead.
Yeah, no, go ahead, Jessica.
No, I think so. And I think, this is where, especially as we really build our workforce to building that cultural competency of our healthcare trainings and staff, there's so much around DEI, but there's also an equity component of this as it relates to the patient and that patient-centered care approach on how best to answer and ask those questions. And this is something where we can help leverage in some policies, procedures, and just asking the right question for that particular patient. Discharge status is always a huge component of any sort of preventive care, and making sure patients are resourced. And, if you live or you work in a facility that may have a higher proportion of homeless patients, there's a different story and question and set of expertise to really streamline those processes to make it easier for the patients, easier for the partnerships in the community in which we best need to be working together to help support the communities that each of our healthcare facilities are actually in. And so that's just a piece of the puzzle. I think, as IPs, we use risk assessment so much, and those are going to be those proportions of that. Do we have the right education to help with the patient populations in which we serve?
Absolutely.
Well, and I think it's and just to add on to Jessica, I think it's as simple as thinking out of our own box. Because I think we all operate in our own comfort zone, and it's our own implicit bias and what we think individually. And I think it's getting comfortable with stepping out of your own box and really putting yourselves in that person in front of your shoes. What are the situations that they're facing? And I think that's a huge step in the right direction.
Absolutely. And one thing that I would contribute, because based on your responses, it also made me think of, even the impact of global health, right? So like I noted, I'm here in Chicago. I know that New York and other areas are dealing with the same thing and being impacted by global health matters, such as humanitarian crises and having, something, for example, new arrivals coming into your city and also providing that adequate healthcare services for those individuals and ensuring and bolstering health equity standards. Share with us the meaning or the difference between equity and equality.
Yeah. Good. And it's a great question. And it's something that really needs to be differentiated because when we're talking about equity, I always have that visualization of, the person, the child trying to look over the fence, the adult trying to look over the fence. And really, when we're talking about the difference between the two, is that equality is meaning that each individual or group of people is given the same resources of opportunities. Okay. But then from an equity standpoint, that's really recognizing that each person has different circumstances and allocates the exact same resources and opportunities needed to reach an equal outcome. So when we think of outcomes, that equality is everybody getting the same resources, where equity is you're given the resources that you need to at least have a fighting chance to have an equal outcome.
Yes. So giving the child a stool to stand on so that they can be the same height as the adult peering over the fence.
Giving a person on a wheelchair a ramp to get up the road instead of the stairs. Just kind of keeping it's not an even playing ground, but everybody is then having that chance to achieve the same optimal health outcome.
So share with us, Jessica, what are some of the challenges and barriers that IPC workforce has in access to education and resources? I know I noted previously, and there was briefly discussed the lack of research related to this specific area. So share more information related to that.
Yeah, there definitely is more so a lack of research on how that relates to the IP's sphere of influence. And, when we look at basic descriptive epidemiology and HAIs, it's the data's getting better. We're still not there yet. I think where it comes to ensure that we're really looking at this and the research that is truly needed are really sometimes in the areas that don't have the resources for data collection. There may not be a robust electronic medical record. I know many of the IPs that are in large systems are either working with EPIC or Cerner or some of the bigger electronic health records. But the problem is when you think about even some of our tribal institutions that's kind of looking at CMS and then state and then the Indian Health Services, not everybody has that same leverage and really support from their administrative team to really look at health equity in the same way as it relates to infection prevention and HAIs. Think about the small critical access hospital, that may be one thing, but if they're not linked to maybe an APIC chapter or a larger system, they may be wearing 1,500 hats, just similar to long-term care or nursing facilities. And so as an organization, that's how best we can serve our infection preventionist is really, really spearheading some basic guides and educational resources to help guide practice guidance. But the challenges and barriers are really, really in tune with the administration of also that facility. So we want to make sure IPs feel like they have a voice as part of being a huge component, a huge factor is kind of speaking to health equity initiatives.
Absolutely. Yeah, I know that this committee and this initiative would absolutely assist in bridging the gap with those IPs that are, under-resourced. It's absolutely integral in order for them to make a positive impact and change on health equity. The department itself or that loaner themselves have to be adequately resourced with the information and the data to further bolster this effort? I know that you noted critical access, but including the safety net hospitals and rural hospitals as well.
Yes, I agree. And this might be a really difficult question, but once we do have that guidance for everybody, at least in the United States starting out, now they have this information. We've led the horse to water, but how can we help them drink, right, without the appropriate resources that may not be forthcoming?
And I think, it's funny, so a couple things that have happened, I mean, at least first steps, because I think this is, a multi-layered onion that just, you solve one thing and have, 10 more things to look at, is APIC Consulting has their critical access scholarship program, and that's funding APIC memberships and resources and coming to APIC conference for some of these not under-resourced, but facilities that maybe don't have the access and the support as single IPs. But I think part of that ties into looking at your APIC staffing models so that you're getting more resources for your IPs. I mean, I know we heard in some of our focus groups, just there's IPs that are maybe working over a full state, and there's one of them, and trying to even just do the minimum of what regulations are makes it almost impossible to look at this ask next. And I think that's where, I think I had to realize, in my background, I was working at a small critical access hospital in Alaska when I first became an IP. And I'm not going to say I was self-taught, and I had a great APIC chapter that I ended up connecting with, but there was a lot of self-learning. And so it's, I think with the mentorship program, I think there's a lot of other things that APIC is currently doing that is pulling all of this together that's just going to make this piece of it a little bit easier to achieve.
Yeah, one thing I would add is just part of the committee work that we've done. So we did do focus groups in 7 different backgrounds. So looking at acute care, public health IPs, they have a completely different perspective than some of the IPs within healthcare, in the healthcare units themselves. And we touched 7 different specialties and backgrounds, and the wealth of knowledge and perceptions and needs of each of the different groups has really helped us to really pick out key themes of health equity and patient-centered care, health literacy. A lot of that has come up, and our goal is to convene with a white paper as highlighting those key themes, and then really working with practice guidance to help support the IPs in each of those domains.
And just one last I was going to say, in one piece more with Jessica saying that, is I think it's just, as an IP, no matter where you are, there are so many IP partners, and I would say other IPs out there. And I think really developing those relationships. So if you're in a hospital, really developing those relationships with your public health IPs that are out there, because I think the more of those partnerships that we solidify, the stronger you are as an IP in your work setting.
That's fantastic information. I'm really excited to read the white paper. And, from an IP's perspective, that is maybe in a rural setting or an under-resourced setting, they're collecting the data in some way, shape, or form. So even if they don't have a robust system to help them collect and collate that data, they are tracking it somewhere. So they could consider adding another column to their spreadsheet, right, with race, so that we can, see how the infections are distributed across certain socioeconomic patterns. So yeah, that's definitely a very good tip. And I like how you framed that. So, and I can tell that you're both so excited about this. I love how you're both jumping in with more to say and more to add. And I love your passion. So what do you see as the future of health equity? I know we're kind of at the very beginning stages with the committee and with this work, but what do you see in the future, and what do we need to do to get there?
Yeah, I think obviously we need more data. We need more research. We want IPs to look at their HAIs, publish their findings. It's going to look so different here in Atlanta, Georgia, than Los Angeles, California. And so we need more data, number one. we have quite a bit in the works. And so Caldwell, you want to cover some of the committee works that we're doing?
Yeah, no, so I think, for us, this has been, a long, hard haul. And I think we are super excited because we finally took off and have really made some significant headway. And I think there's exciting things that are coming out. But it's really looking at partnerships with different, even professional organizations. I think it's the partnerships with the various IP work settings. It's looking at like your professional development and making sure that you're inclusive of infection preventionists with different backgrounds. I mean, whether it's nursing, whether it's your med techs, or if it's your MPHs, I think we all have, very valuable perspectives. And I think when you bring those groups together, you can have, it's amazing how much more knowledge and scope of view that you have. I do think, one of the things that we want to continue to do as a committee is develop more information to really help the knowledge base for IPs on how they're looking at health equity, how they can integrate it into their practice, again, whether, where that's starting, and then also helping to partner with the other APIC committees to really make more, and not to say that we don't have robust conversations, but make more robust education that really factors in those health equity, aspects of it. And then the other thing we're doing is partnering with other organizations to really strengthen what's being, put forward. Because if you look across the scope, I think every professional organization is developing some form of health equity, digging into this topic. And, it all does merge together. So how do we strengthen that?
Yeah. And then, we definitely want to be cognizant that a lot of these priorities right now, as part of the Health Equity Committee, has really been centered around North America. But we do realize and know that we have many APIC members that are in the Middle East, that are in different countries, and health equity and some of the tactics may be a little bit different, just pending, a lot of our focus right now on CMS funding. CMS funded facilities may look very different than in the Middle East. I think ultimately health or social determinants of health and health equity strategies, it's everywhere. Every country has opportunities. We are definitely very advantaged here in the United States and in North America. We still have a lot of work to do. But, the overarching goal is to really have kind of standard playbooks and some practice guidance to help support also some of our underfunded countries as well.
That's absolutely integral, especially, with this, having that global health component within the committee. I think that that's absolutely pertinent for this initiative. And, Caldwell, Jessica, I really thank you and appreciate you for coming on the show and having this conversation, much needed conversation with us. I know one takeaway that I have among many, just imploring the listeners and IP stakeholders to ask themselves what culturally competent questions they can ask to move the needle forward on health equity. And then I also look forward to inculcating, health equity within our IP workflows, utilizing the resources that stem from this committee.
Yes, I second that. I am so grateful for you two for, spearheading this project, for being part of it, for giving your time. And it's really important work. I really look forward to reading the white paper, and thank you so much for joining us today.
Thanks for listening to APIC's 5-Second Rule Show. We want to hear from you. Visit us at www.5secondruleshow.org. That's with the number 5, where you can contribute to the conversation. Make sure you subscribe and rate us wherever you listen to your podcasts. We're so appreciative of the hard work each of you do every day to make a safer world through infection prevention. Remember, IP stands for Important Person. You are awesome. Stay safe, and we'll see you next time.